Welcome to KJR SummaryCast. SummaryCast provides audio summaries of KJR articles created using an in-house AI tool with editorial or author review. For full details, please refer to the original article.
Welcome to SummaryCast. Today we're looking at a paper that goes right to the heart of quality assurance in breast imaging. It's not about a new scanner or a novel contrast agent, but something arguably more fundamental.
Right. It's about the rulebook, how practices measure their own performance, find blind spots, and standardize the data they collect.
Precisely. The paper is titled How BI-RADS version 2025 Helps Patients, New Audits and Method of Detection, published in the Korean Journal of Radiology.
BI-RADS version 2025. So this is a review of the big updates in the latest manual. What are the key changes the authors are flagging?
They detail several, but they organize the review around three major updates that expand breast imaging audits beyond traditional metrics.
Okay, what's the first one?
A new recommendation for routine auditing of BI-RADS Category 3 assessments.
The probably benign category. That one has always seemed to carry a degree of subjectivity, so adding a formal audit makes some sense.
That's the impetus. Second, they introduce a new framework for auditing preoperative breast MRIs performed for staging, the ones used to assess the extent of disease, or EOD.
Got it. And the third?
The third is a big one. It's a push for the prospective assignment of the initial method of detection, or MOD, to link cancer outcomes directly back to how they were first discovered.
How the cancer was actually found. That feels foundational. Let's dig into these. Where do you want to start?
Let's go in order, starting with the new audit for Category 3.
Okay. What was the problem that prompted this? Overuse?
The paper suggests exactly that the category can be used inappropriately, leading to either unnecessary follow-up exams or, worse, delays in diagnosis.
So the goal of the audit is to enforce its intended use for findings that have a 2% or less likelihood of malignancy.
You nailed it. And to do that, they recommend tracking a few key metrics, but they make a very specific point about what to include in the calculation.
Which is?
The audit should only monitor the initial Category 3 assessment for a given finding.
Ah, that's a key detail. So you don't count all the subsequent BI-RADS 3 assessments from follow-up exams for the same stable finding.
Exactly. Doing so would erroneously inflate the denominator and give a false sense of security about the malignancy rate. A tidy piece of methodological guidance.
Makes sense. So what are the new performance metrics for this audit?
The authors walk through an example in figures 1 and 2. Let's imagine a practice performing 500,000 screening examinations.
Okay.
Out of those, maybe 50,000 are BI-RADS 0, meaning they get recalled for diagnostic imaging.
Right, the 10% recall rate in this example.
And of those recalled patients, 5,000 are ultimately assigned an initial BI-RADS 3 after their diagnostic workup is complete.
So one of the new metrics is that calculation right there, the percentage of screening exams that result in an initial BI-RADS 3 assessment. In this case, 5,000 out of 500,000, which is 1%.
That's it. But the more critical metric, of course, is the cancer diagnosis rate within those 5,000 cases.
The positive predictive value of the BI-RADS free category. This is the check on that less than or equal to 2% rule.
Correct. The manual recommends using a 2-year standard ascertainment interval, or SAI, for this specific audit.
Why 2 years?
The paper notes it's the most common duration for imaging surveillance of these findings in the United States. So, in their example, how many of those 5,000 initial BI-RADS 3 assessments were ultimately diagnosed as breast cancer within 2 years?
What's the number?
According to the calculation in Figure 2, it was 77 cancers.
Okay, 77 out of 5,000. That's a malignancy rate of 1.5%.
Which falls comfortably within that acceptable less than or equal to 2% threshold. So for this hypothetical practice, the audit provides quantifiable evidence that they're using the category appropriately.
It's a gut check, backed by data. It moves the conversation from, I feel like we use it correctly, to, we can prove we use it correctly. Let's pivot to the second update, auditing EOD MRI.
Right. auditing diagnostic breast MRI performed to determine the extent of disease.
Why was this considered a blind spot in previous auditing frameworks?
Well, it's because the majority of these examinations are assigned an overall BI-RADS Category 6 for known biopsy-proven malignancy.
And Category 6 exams are excluded from traditional performance audits.
Precisely. But the clinical purpose of an EOD MRI isn't to re-diagnose the known cancer. It's to find additional, previously unsuspected disease, either in the same breast or the contralateral one.
And performance in that task was going unmonitored.
Exactly. So this new audit framework is designed specifically to measure that performance. What's particularly clever here is that it operates at two different levels.
2 levels? Define that.
Examination level and finding level.
So one level asks, did this MRI examination as a whole lead to the discovery of an additional cancer? And the other level asks, for this one specific suspicious finding noted on the MRI, what was the outcome?
You got it. The abnormal interpretation rate, or AIR, is an examination level metric. It's the percentage of EOD MRIs that are interpreted as positive, meaning they have suspicious findings beyond the known cancer.
Okay, and the other metrics?
The positive predictive values and the additional cancer detection rate, or ACDR, are calculated at the finding level.
ACDR. How is that defined?
It's the number of additional cancers diagnosed per 1,000 EOD MRIs. It quantifies the yield of the test.
What does their example show for that?
In the flowchart in Figure 3, they start with 5,000 EOD MRIs. These exams identify 2,000 suspicious findings distinct from the index cancer. After workup, 655 additional cancers are found.
So the ACDR would be 655 divided by 5,000, then multiplied by 1,000. That's 131 additional cancers per 1,000 EOD MRIs.
That's the overall ACDR. But the paper's broader recommendation is to split the EOD MRI audit by laterality: ipsilateral, contralateral, and overall.
Why split it by side? Isn't the headline number enough?
Not really. Ipsilateral findings tell you about mapping additional disease around the known cancer, while contralateral findings tell you about detecting a separate cancer in the other breast. Keeping those buckets separate makes the ACDR, AIR, and positive predictive values much easier to interpret.
Okay, that brings us to the third major update, which you flagged as potentially the most impactful, the method of detection.
Right. The MOD is defined as the first test or clinical event that triggers the workup, which ultimately leads to a histological diagnosis of breast cancer.
So, was it a screening mammogram? Was it a lump the patient felt? Was it an incidental finding on a CT scan performed for another reason?
All of the above. Table 1 in the paper lays out the categories. Category S is for screening, with subcodes for mammography, ultrasound, MRI, and so on. Category P is for patient or provider-detected findings, and Category N is for all other pathways.
This seems like such a fundamental piece of data for each cancer. What's the core problem this is trying to solve? Why the push to collect this now?
The authors make a striking point. Major national cancer registries in the U.S., like the SEER database, have never included the method of detection.
Wait, that's a huge gap. How can you effectively evaluate the population-level impact of a national screening program if you don't systematically track which cancers are found by that program versus other means?
You see the problem. Policymakers and organizations have to rely on models based on historical data. The paper argues that this lack of fundamental data fuels the conflicting recommendations and public confusion around breast cancer screening.
Table 2 lists some of the research questions this could help answer. Things like, do patients with screen-detected cancers have different treatment or mortality outcomes? And are there racial or ethnic disparities in screening that impact outcomes? These are the billion-dollar questions in public health.
And they've been remarkably difficult to answer with existing data. This proposal aims to fix the data collection at its source.
So who assigns the MOD and when?
The recommendation is for the radiologist to assign it, prospectively, at the time they issue a BI-RADS 4 or 5 assessment.
So it becomes part of the standardized reporting workflow, just another field to complete.
Right. The diagnostic radiologist who is recommending the biopsy is in the best position to review the patient's recent history and imaging to determine what single event triggered the workup.
The paper includes a few case studies to show that this isn't always straightforward.
Yes, Figure 5 is a perfect example of the nuance required. A patient presents after feeling a lump in her right breast.
Okay.
The diagnostic workup, including mammogram and ultrasound, confirms the palpable finding is just a benign cyst. Case closed, right?
But it's not.
It's not. Because the patient has dense breasts, the radiologist decides to perform a handheld screening ultrasound of both breasts during the same visit. And incidentally, a small suspicious mass is found in the contralateral left breast.
And that turns out to be cancer.
That turns out to be cancer. So what's the MOD? It wasn't found by a routine screening exam, but the exam that found it was a screening ultrasound.
What's the correct assignment?
The correct MOD is PAT, for patient detected. The logic is that the patient's symptom, the lump in the right breast, was the single event that triggered the entire diagnostic episode. Without that initial clinical presentation, the cancer in the other breast would not have been found that day.
That's a subtle but critical distinction. It's about the chain of causation. The assignment requires careful thought.
It does. It requires understanding the full clinical context, which is why the diagnostic radiologist is uniquely positioned to make that call.
So let's land this. We have 3 significant updates to the BI-RADS auditing manual. First, formalizing the audit of Category 3 assessments to ensure they're used correctly. Second, creating a new multi-level audit for EOD MRIs to monitor performance in detecting additional disease. And third, introducing the prospective assignments of method of detection.
Stepping back, the common thread seems to be a move towards more granular, comprehensive, and meaningful data collection. It's about building a framework that can answer more sophisticated questions about quality.
It feels like a shift from examination-level outcomes to finding-level and even patient-level outcomes. The MOD concept is the clearest example of that. It's not about the performance of one exam, but about the patient's entire pathway to diagnosis.
The authors frame it as laying the foundation for future benchmark development and global standardization. By defining these new audits and data points, they're creating the infrastructure needed for more robust research down the line.
The method of detection piece, if widely adopted, seems like the real game changer. The potential for policy and population health research is enormous.
It is, but its success hinges on consistent and accurate assignment by thousands of individual radiologists in their daily workflow. That's the hurdle.
Right. But by building it directly into the BI-RADS system, the ACR is giving it a powerful structural nudge. Bottom line, these changes expand the scope of auditing far beyond traditional metrics and provide a more complete framework for quality assurance and improvement.
A thoughtful evolution of a critical system. And that's our summary.
Thanks for tuning in.